Chris, how do you feel about opioids in this spectrum of treatment of neuropathic pain? How do you choose the right patients?
Opioids are broad-spectrum analgesics. They can certainly be effective in neuropathic pain as well as musculoskeletal pain, but I think one of the underlying principles of opioid pharmacotherapy is that they're not first line. Generally speaking, for chronic pain, you want a good, solid diagnostic indications for opioid pharmacotherapy, and along with appropriate psychosocial circumstances, as well as failure of non-opioid therapy. So after your patient has failed acetaminophen, anti-inflammatories, antidepressants, anticonvulsants, physical therapy, and they're just not getting anywhere in terms of their function, they become reasonable candidates for an opioid trial. And with that comes a certain degree of responsibility in terms of their follow-up. But I think it's important to emphasize to patients that we're not just done with non-opioids. Opioids deserve a trial, a reasonable trial, and it's something we can give it a try on.
You know, in the last decade or so, every national pain meeting that I attend talks about risk assessment tools, needing to properly screen your patients and stratify them for the risk of misuse of opioid analgesics. Vitaly, what kind of screening tools might you use in your clinical practice?
If I may, Jeff, even before administering the risk assessment tool, I would like to review the patient's medical records. I want to know whether the patient was seen by multiple other physicians, what is called doctor shopping. One of the most common, there are multiple tools, as you mentioned, multiple risk assessment tools. One of the most common and the easiest risk assessment tool is opioid risk tool. The opioid risk tool is very simple. It takes about 30 to 40 seconds to administer. It assesses patients' family history for opioid and substance abuse, assesses patients' personal history for opioid and substance abuse. One of the increased risks is pre-adolescent sexual abuse in females, younger age, up to younger than 45 years of age, and any untreated ongoing psychiatric condition. So this is a very simple and quite reliable tool, actually was validated in several languages and so forth. There are multiple other risk assessment tools. One of the most common one is SOAP, a risk assessment tool, which is screener and opioid assessment for patients in pain. I personally do not administer that, but I refer to a psychologist with whom I work who administers that tool. It's a very reliable tool, also was validated in multiple studies. It has 3 levels of risks: mild, moderate, and severe. Another very simple tool or a diagnostic study, of course, is urinary drug test. And when you administer that, you want to see that the patient is taking what is being prescribed, and nothing that is not being prescribed is not in the drug screen.
So you mentioned a number of tools. I think it's important for our viewers to know that we're not recommending any one particular tool, but we are recommending that they do some kind of screening. And you mentioned urine drug screening, which perhaps we'll have a chance to talk about later.
Jeff, one point on there, though, I think that we have to really be aware of is if you look at multiple logarithmic regression analysis, I think there's 2 points that everybody needs to be aware of. If they have a prior or family history of abuse of alcohol or drugs or a misuse of prescription agents, and also if there's a family or personal history. So it's not just the personal, but the family history of major depressive or psychiatric illnesses. And I think they should be right on the top of our lists every time we're doing it. And the other thing we should realize is that there is no one absolute perfect risk screening tool. And it gets down to the idea of what is the predicted prevalence in chronic pain patients like I treat that actually will become addicted or abused. A lot of the information we have on addiction and abuse are not in chronic pain patients. And so we are extrapolating a lot of this behavioral data to these patients. And Christopher and I have published papers that chronic pain patients are different than the average patient out there who may be recreationally using these drugs. It's a different psyche and different things that are going on. So yet these tools are good for screening. There is no one absolute screening tool that is out there, nor a biomarker that we can use.
So, oh, sorry, Chris.
Also keep in mind that whatever risk that your patient is presenting with, that risk is constant, dynamic, and really depends on the circumstances. Things happen in life. Somebody could be very much low risk for many years, and then something catastrophic happens. Their spouse dies, their loved one dies, and all of a sudden they start the chemical cope. So there needs to be ongoing surveillance, constant monitoring to monitor the risk level.
So it sounds like for